Good evening, members. Good evening, officers, and good evening to any of the public that may be watching. This is the Health and Adult Social Care Overview and Scrutiny Committee, 24th of May 2021 at 6 o'clock. I'd like to ask Joe now to read through the housekeeping.
Thank you, Chair. Please note that this meeting of the Health and Adult Social Care Overview and Scrutiny Committee is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. Please could everyone present follow these ground rules. Only speak when invited to by the Chair. For those present in the meeting room, please use the microphones on your desk when speaking. Please turn off your microphone when you are not speaking, as this is to assist the video feed. If accessing the meeting and addressing the committee via Microsoft Teams, please turn on your video function before speaking. Again, if you're accessing via Teams and would like to speak on an item, please do so by utilising the Raise Your Hand feature in the bar at the top of the Teams window. If during the course of the meeting there is a move and a vote, the Chair will call out each committee member's name and will ask the member to respond with a for, against or abstain. This again is for the purpose of the video broadcast. For those of us in the room, please note that if alarm sounds, you must exit the building by way of the nearest available signed fire exit route and make your way to the ground floor of the multi-storey car park. Finally, please ensure background noise is kept to a minimum and that mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you, Chair.
Thank you, Joe. Joe, have we got any apologies for this meeting?
Thank you, Chair. Yes, we do. We have received apologies from Councillor Dwayne Farr, Councillor Cheryl Johnson and Councillor Chris Matthews. And subsequently, with item 2 substitute members, we have Councillor Brian Dion substituting for Councillor Cheryl Johnson, Councillor Sarah Anderson substituting for Councillor Dwayne Farr, and Councillor Millie Earle substituting for Councillor Chris Matthews. Thank you, Chair.
Now moving on to agenda item 3. Election of Chair for the 2021-2022 municipal year. Have we got any nominations from members for the role of Chair, please?
Put one forward if I may. Do I give my address now or is it just a name you're looking for?
Just the name, thank you, sir.
Just a name, Jackie Edwards. Councillor Jackie Edwards.
Do we have any seconders?
Yeah, I'd like to second that, please, Chair.
Thank you, Councillor Jones. Have we got any other nominations? No.
That means you're duly elected Chair. Thank you, Councillor Edwards.
Am I not allowed to give my tiny little address, Madam Chair? To be, perhaps, or not to? You are going to be. But anyway, may I just say a few words?
It's up to you.
I'd like to.
As long as it's just a few words.
It is just a few words, yes. Right, it gives me great pleasure to propose Councillor Jackie Edwards, who unanimously now has been voted as chair of this panel. I've known Jackie for many years and can confirm that she is and always has been dedicated, not only as vice chair, but as a chairperson too. She has empathy, compassion, and always strives to make a real difference. She is without doubt worthy of remaining in this post, and please look upon the proposal which has just been placed on you. And I'm pleased that it's you, Jackie. Thank you.
Thank you, Councillor Phillips. Agenda item 4, election of vice chair for the 2021-2022 municipal year. Do we have any nominations? Councillor Wilson.
Thank you. Can I nominate Councillor LJ Evans, please?
Thank you. Do we have any seconders? Councillor Robson.
Yeah, I'm happy to second that proposal.
Do we have any other nominations for vice chair? No.
Yeah, once again, Councillor.
Agenda item 5, declarations of interest. Have any committee members got any declarations of interest? No. Oh, Councillor
Thank you. Just for transparency, I'm a bank employee of University Hospitals Dorset.
Thank you. And agenda item 6, the minutes. Do we have confirmation minutes? Does everyone agree to confirm the minutes, or have we got anything they want to raise about the minutes from the last meeting? No, that's confirmed. Thank you, Joe. Joe, do we have any public issues for this meeting?
There are no public issues for this meeting, Chair. Thank you.
Thank you, Joe. Agenda item 8, the action sheet. Does any members have anything arising from the action sheet that you have on your agenda? No? Okay, thank you. Agenda item 9, the COVID-19 update. Can I call upon Jan Thurgood and Sam Crow to introduce this item, please?
Thank you, Chairman. I'm going to hand over to Sam Crow, who's going to start off the presentation by talking in relation to public health issues. He'll be followed by David Vitti, who's going to talk about adult social services delivery, and Phil Hornsby, who's going to talk about adult social care commissioning and our work with the adult social care sector.
Thank you, Jan. So, Sam, thank you.
Thank you very much, Jan. Thank you, Chair and Committee. So I'm going to start with just a summary of the public health. And forgive me, as this is a hybrid meeting, I'm not clear whether you've been provided with the presentation or not. Thank you, Joe. That's really helpful. Now I can see what you're seeing, and I'll start to go through the slides in order. Overall assessment of the current situation is that we are very fortunate to have low infection rates in the BCP council area, very, very similar to other councils in the southwest. At the time of putting this presentation together, our infection rates were lower than the rate for England, around about 10 per 100,000 for the 7-day period between the 9th and the 15th of May. Since that time, we've continued that downwards trend, and when I last looked today, we are seeing very low numbers of cases across both councils, maybe 2 or 3 per day. The infection rate across the southwest is also quite similar at 9.4. And at the time this presentation was put together, we were in the fortunate position of not having any people in hospital with COVID-19, which was the first time that we were able to say that for many, many months. So a really positive situation. One of the things that I'm most encouraged by is that as we've started to progress through the roadmap and we went through that step 2 of easing of the lockdown restrictions, we didn't see any spike in our local infection rate. And of course, we've since had the announcement of the further loosening of measures, and we'll be watching developments very, very carefully to see whether the measures that were announced as part of step 3 under the roadmap from the 17th of May will lead to any local increases. And of course, we hope that won't be the case, but we are remaining very, very vigilant just to make sure that we're keeping a close eye on our local infections. It's slightly, and I thought I need to make committee aware of obviously the national coverage that's been happening in relation to some other councils that have been with not only an increase in infection rates in younger age groups, but the variant from India known as B1.617.2. So in some areas in the northwest, there have been quite significant increases in cases, and that's led to local surge testing. In those areas, there has been community transmission associated with that variant, but I'd like to assure the committee members that currently it's not an issue locally. So we have had some cases within the southwest, almost all connected to recent travel, and in the vast majority of cases, those people have spent their infectious period in a managed quarantine hotel as a result of the the processes that start when they return to this country. But we are obviously watching what's happening in the rest of the country with interest. And again, I'd like to assure committee that both councils, BCP Council and Dorset Council, have well advanced plans in case we need to stand up surge testing in response to those variants. The vaccination programme is contributing, I think, hugely to our fortunate position. It's progressing extremely well locally. So again, when we put this presentation together, the figures that you can see, 82% of people in the 40 to 49-year-old age group had their first progress being made with vaccinating younger age groups. Nearly half of 30 to 39-year-olds had their first dose, and an increasing number of people locally having had their second dose. And remember that the dosing interval has been brought forward to 8 weeks, particularly for people who may be more vulnerable. So we would expect Dorset to be well ahead of that national schedule of completing both jabs by the deadline of the end of July. I think at this point, I just wanted to say a few words on the use of the local vaccination centre. So the mass vaccination site at the Bournemouth International Centre has been the subject of speculation about the plan to potentially stand down the operation at the BIC. So as the national COVID-19 restrictions ease, Dorset CCG has said that they are trying to work with the BIC to understand how they can pre-planned events to run as usual. And the vaccination service that's currently been hosted in the Purbeck Hall will temporarily pause to allow a pre-planned event to take place. Currently, the vaccination centre won't be operating between the 21st of June and the 18th of July, and that's in order to allow time for the packing up of the clean the Purbeck Hall and to set up for the event so that it can run. And during this time, Dorset Healthcare, which is the main provider of the service, will be working with partners to continue to offer the vaccination programme to local communities. There are many other ways that people can have their vaccine, including primary care, but also increasingly outreach vaccination. And Dorset CCG have also asked me to make the committee continue to choose from a range of options as to where they have their vaccination. As I said, that includes some of the primary care sites and also an increasing number of community pharmacies where they're invited to have their vaccine. So that was a statement from Dorset CCG, which we thought committee would want to be aware of, especially as the issue has been covered extensively recently. My next slide just shows you the 7-day infection rate per 100,000 population. Looks like you might have an old slide in this version of the presentation. If you could move on to the next one, please, that'd be great. So thank you. This again looks like a different slide to the one in the presentation that I have. I may need to resend the slides after this presentation so that you have the accurate one. The slide that I'm talking to at the moment shows that the low infection rates are also continuing in our neighbouring councils. So this slide shows the position in Hampshire, Somerset and Wiltshire councils. The only council locally on our patch that's still got slightly higher infection rates is Southampton, which had a weekly case rate of 29 per 100,000. But overwhelmingly, most of our neighbours in a very similar position to BCP Council with infection rates around about 10 per 100,000. If you could move on to the next slide, please. So at the last time I addressed committee, I used this slide just to set out some of the current public health response issues. At the time, we were refreshing our local outbreak management plan, which was published in March, and we set a number of priorities as to how we were considering the public health response as we live with COVID-19. And what I've done is just provided some brief updates in red against those main priorities in the plan. The first one about responding to outbreaks. Fortunately, we're seeing a very, very low number of incidents and outbreaks at the moment, and that's a really good position to be in, but we're not being complacent. Just in case we do start to see an increase in infection rates and a return to some of those outbreaks and incidents, we've taken the step of starting to bolster our day response team. So we've had almost 26 members of the public health team joining that day response team throughout the COVID pandemic. Obviously, maintaining that degree of effort takes a huge amount out of the team. So using our national money that comes in through the Contain Outbreak Management Fund, we're bringing forward a number of fixed term roles, which will continue to provide that day response, working with our health protection consultants to make sure we continue to provide that rapid response. On community testing, we did the early part of the year to bring forward those national offers to stand up regular routine asymptomatic testing for a number of groups. The work across both councils was really impressive. We started with a number of employee groups who were having to go into the community, and because of their role, we offered them asymptomatic test. Has since changed substantially through the bringing forward of a number of different channels. So now all adults are able to order lateral flow tests from the government direct or use the pharmacy collect service to take part in regular twice weekly testing. That programme will continue. The government has confirmed that they will continue to invest in community testing, but it's likely that there'll be more of a focus going forwards on vulnerable groups who may not be able to access testing via those postal and pharmacy channels. We continue to work closely with NHS Test and Trace, and that situation's changed hugely over the past few months. We've now implemented a system called Local Zero across both councils. This means that the contact tracing teams in each council can draw cases directly from the NHS Test and Trace system with no delay. So previously, we would have to wait for that data to come from NHS Test and Trace. They would do the first calls, and then anyone they weren't able to contact would be passed to local councils to make that contact. That situation has now flipped around. So councils now make the vast majority of those contact tracing calls first, and it's only the more complex cases that are triaged and sent up to the regional health protection team. And the completion rates are very high. So because the case numbers have fallen, obviously that means less pressure in the system. The last time we had updates from both of those services, they're managing to reach almost 100% of those cases, which is fantastic news. We continue to obviously keep the local situation under surveillance. We're continuing our local group called Epidemiology Cell, which meets on a regular basis to consider all of the data. We look at the data on a daily basis just to make sure that we're cited on any change in the current situation. I've talked a bit about the vaccination programme, but one of the things that we are working very closely with Dorset CCG and other providers on is assurance over the coverage of the vaccination. So working hard to close any gaps in uptake, making sure that we've got some really good interventions planned with different communities that may not be taking up the vaccine as quickly as some other groups. I'm pleased to report that our inequalities plan, which was developed with Dorset Healthcare and Dorset CCG, was approved by NHS England, along with additional new funding to support that work. And the public health team remains pretty closely involved in supporting the delivery of some of those interventions. And finally, I have also talked about the planning for surge testing. Plans are in place under both councils to stand up that emergency testing should it be required. So we're in a good place locally against some of those priorities in the outbreak management plan. If we could have the next slide, please. So I think this is my final one for tonight. The key issues over the next few weeks will be maintaining confidence in adherence to the public health measures. I think it's going to be really important how our local population responds behaviourally, because as we loosen up, the way that people interact, particularly indoors, is going to be absolutely key and absolutely crucial. Obviously, the Prime Minister's talked about the need for people to be mindful of their own individual risk and perhaps the risk to others if they're starting to reduce social distancing and perhaps cuddle with caution. We have had a fantastically compliant population so far. By and large, I think it's down to the efforts of our community maintaining, the efforts with those public health measures and being really, really cautious that's kept us largely in a good place. So it's a little bit of an unknown how people will react as we go through step 3 of the roadmap, but I'm hopeful that most people by and large have taken an extremely sensible approach to being very, very will continue to do so. We remain vigilant on the spread of variants of concern, and the national surveillance and the data that we get on those variants is confident that we would be able to respond quickly if we were notified of any variants where we needed. We'll continue to ensure that that vaccination offer is taken up as widely as possible, and we remain very alive to the risk that as national mobility increases, we continue to run the risk of importing infections from some other areas with higher infection rates. But again, the summer planning that's been in place and the preparedness by all agencies for the summer period has been really, really impressive. We'll continue to monitor infection rates in the unvaccinated population. So at the moment, there's a big focus on looking at what's happening in the under 30s. Not seeing any particular increases in infection rates to be concerned about, but we will keep that under close review. We need to deploy behavioural insights and communications work in response to any signs of a local increase. That's all from me by way of my update tonight. I'm happy to hand over to other colleagues to continue the presentation. Thank you, Chair.
Thank you, Sam. Actually, had a question for you. Was it for Sam, Mark?
Yes, or any other member of the team, really. Sam, it's just on the data there and the vaccination process, very, very impressive. I just wonder if any data on actually the take-up of antibodies in individuals that have had these, all the injections and the jabs and so on. The rate could be falling because of lockdown, all the other measures that have been taken place. But is there any data so far on actually the production of antibodies in injected people?
Thank you. It's a really good question. So there are a number of national studies that we don't have any data locally that I'm aware of, but we draw conclusions from those national studies which are looking at samples that are fairly representative of the population. And there was a study published over the weekend, particularly in response to some of the concerns about whether vaccines will be effective, those variants, which showed pretty good effectiveness against not only which has been our main dominant strain to date, also the B16172 strain. So both of the main vaccines that have been used substantially in this local area, if you have 2 doses, pretty compelling evidence that they are achieving high levels of effectiveness. But it is a really good question. It's a really good point. And, there are sometimes questions asked about why some of the national modelling has predicted infections. If the vaccination programme is going so well and so many people are covered, why are some of the national models forecasting an increase? And that could be explained in part because sometimes people aren't able to mount always mount an effective immune response. So we always have to be mindful of that. It isn't necessarily a panacea. We need to get the rates as high as possible, but also remember that if we're in a situation where there are signs that the COVID virus is spreading again in the community, we have to go back to those sort of 3 important measures: having the vaccination, having 2 doses, making sure that we go back to observing those public health measures, social distancing, hygiene, the importance of ventilation, and also twice weekly lateral for taking part in that as an adult is a really important way that you can protect yourself and also protect others from asymptomatic infections. Spotting that at an can isolate promptly and break the transmission.
Great, thanks, Sam. Thanks.
Thank you. Has anybody else got any questions for Sam Crow while he's here? No? Can we move on to, is it David Vitti next? Thank you.
Thank you, Chair. If I could just share 2 or 3 slides to update you on our operational adult social care services. The first point is just to recognise that hospital discharges still remain very high. Not particularly because we have a large number of people in hospital with COVID-19, but because, well, recently the hospitals have seen increased numbers of emergency admissions, but also, of course, there's a programme to catch up on elective surgery. So it still remains very important as part of COVID recovery for us to support people very rapidly out of hospital. It's true as well that the uptake of respite care continues to be relatively low. This is almost certainly because individuals and the people who care for them are nervous for respite. We think as confidence returns, more and more people will take up respite care. In fact, we know our carers are very tired. They've been caring for a year with often very little break. And so we expect that demand to increase in the next few months. And then similarly, themes that we've seen throughout the last year of increased safeguarding concerns being raised with us, and an increase in the number of Mental Health Act assessments that we've had to complete because of the impact of COVID-19 on people's mental health. Those 2 factors are still raised, but I think things are gradually returning to normal, but they're not quite yet at pre-pandemic levels. So, Joe, if we could, thank you, move on to the next one. So the Coronavirus Act 2000 introduced easements to the CARE Act, which allowed local authorities to scale back some of their statutory duties in response to COVID-19. That's now ended, and we are operationally and slowly getting back to business as usual and moving into a recovery phase rather than an incident response phase. But having said that, I would point out that our day centres are still closed, at least closed to business as usual. And that's simply because we can't maintain safe social distancing within the centres they're often quite crowded when they're fully occupied. Tricura, though, our main provider of day services, are providing alternative daytime activity for people both in the community and in their own homes. And we also run some emergency daytime provision in the day centre buildings themselves. So we hope to get back to day centre operation as soon as we can, but at the moment it remains quite limited. We've also restarted carer support groups for the last year, and for most of the time for the last support carers to meet to support each other through video conferencing, which has been fine and really appreciated by many of our carers, but it's not the same as face-to-face groups. And so we've just this week begun COVID safe and with small numbers, but carers are now able to meet and support each other again. We were concerned throughout the last 12 months about the impact of COVID on our staffing levels, both in terms of self-isolation and people who had contracted COVID-19. Actually, the numbers of absences were lower than expected, and they are now really back to normal. In fact, our sickness absence levels are lower than we would expect. And certainly we consider this to be a far reduced risk now of having large-scale staff absences. The 4th bullet point there does recognise that despite the fact we are moving back towards business as usual and recovery, there are still pressures on carers, and as I've said, pressures on people with a mental illness, and actually our staff as well. They've worked incredibly hard over the last year. Many are very tired. They're still working to some extent in pressurised circumstances, particularly those people working in the hospitals, our mental health and safeguarding services. But there is now an opportunity for our staff to take leave.
Just on that one, sort of quite often after the storm, when you're working flat out on a natural adrenaline high, people do push on, and after the provision for possible fallout there of welfare issues amongst the staff and support for them.
Yes, Dorset Healthcare have actually been offering staff, including BCP staff, welfare support programs, and some of our teams have actually taken that up, and as a team been through a process of debriefing and support after the events of the last year. There's also quite a comprehensive BCP welfare package to support staff. Quite a few staff actually carried leave forward to this year because they weren't able to take it last year. So we're also encouraging staff, as I've said, to take their leave because they're ready for it, they've earned it. So yeah, we're very, very alert to the welfare of our staff. And then the last bullet point on this slide is about the home first approach. It's been necessary over the last year to move people out of hospital very clearly in order to free up capacity. And to do that, we've provided, with our colleagues at Dorset Healthcare, a wraparound support and care service, which is all about recovery at home rather than in hospital where it's safe to do that. That process is called Home First, and that's been funded by government. And it's been announced that funding will carry on until the end of September of this year. And in fact, if we go on to the next slide, I'll talk a little bit more about Home First. So this was set up as an incident management response. Essentially, at the beginning of the pandemic, we did need to clear hospital beds very quickly. But actually, it's very good practice as well. People don't do well staying in hospital longer than they need to. And so recovery at home with a good quality support package from both health and social care is undoubtedly a model for the future. And so we're working with our partners in health to move this from a fairly rapidly put together incident management response into a long-term plan for hospital discharge and recovery for the future. So there's work going on around that now. That's probably all I wanted to say from an operational perspective. And unless, Chair, you'd like to invite questions.
Thank you, David. Yeah, I believe Councillor Jones has a question.
Yeah, thank you, Chair. David, you mentioned about an increase in mental health assessments. Are you able to put some kind of scale on that? And also, how long do those assessments take roughly to go through the system, through the various stages?
Well, these are assessments under the Mental Health Act, so they're a response by social workers and doctors to people in extreme distress because of their mental health, people who may be at risk to themselves or others. So these are immediate assessments. They're carried out within minutes or hours of the alert coming in. And sadly, they often result in people being admitted to hospital for assessment under Section 2 of the Mental Health Act. So they're very quick assessments. Now I don't have the numbers with me, but we're seeing probably about 20 to 30 additional assessments every week. That's probably double. They fluctuate a great deal. So some weeks we have more, some weeks we have less. But we can see double the number of mental health assessments over the last year than we would have seen prior to COVID. That has now settled down a bit, but I'm afraid I don't have the current numbers.
Thank you.
Members, anybody else got a question for David? Councillor Butler.
Do you think in the future we might have some more units used for the Home First system, like a halfway between hospital and home, more in the community?
It's a good question. At the moment, people either go straight home from hospital for recovery, which is probably the best option for most people. But we do have step-down beds in care homes, so people can move from a hospital to a care home for 1, 2, 3, 4 weeks before then ultimately moving home. The difficulty with that, of course, is people people can stay longer in care homes and become quite dependent on the care home environment. So it does make sense to move people straight back home. So I think whilst there will always be a need for step down beds between hospital and home, I would much rather see a more comprehensive package supporting people at home to get them home from hospital rather than intermediary steps. So I think it's unlikely that other types of halfway house service will be developed, but we don't know. We're developing our services for the future, so that may be something that's considered.
Thank you, David. Any other questions for David? No? Phil Hornsby, thank you.
Thank you, Chair. Just continuing on the same theme as David was talking about in relation to Home First. This slide, just one of the key aspects of Home First is how do you enable people to be as independent as possible once they've left hospital, or actually prevent them from going into hospital in the first place. So one of the current activities is to review the intermediate care model that we have between health and social care, and coming up with a design which is much more integrated than it is at present. So at the moment we've got services such as reablement that the council provides through Tricuro and its own in-house service within the pool locality, but also intermediate care through community hospitals, through the short-term bedded capacity that we have, that we deliver through 2 care homes across BCP, and also things like district nursing and other interventions that health provide. And that's not necessarily joined up in a way that wraps itself around that individual. So quite often it's a disjointed approach. So we try to come up with a model that would join things up much more closely, so that you would get a collaborative approach with health and social care professionals working together. And just to try and explain what intermediate care is in the context that I'm talking about, it's about short-term support. So usually for 2, 3, up to 6 weeks, working with you around goals that you jointly develop with the professional. So it could be a therapist, such as a physiotherapist or an occupational therapist, would agree the outcomes you want to achieve, the goals you're trying to achieve. That could be just self-care at home. That could be something as simple as making a cup of tea if you've had some sort of crisis, such as a stroke that's disabled you in some way or incapacitated you. But if you live at home and you're starting to struggle with some of your daily tasks, then that's also where we could become involved much more than we do presently, to try and make sure that you can live and cope longer in your own home, and reduce the likelihood of things like falls. So that's a focus that's going to be developed over the coming months. And we're also working together with partners, and as David said, Health and Social Care is coming up with a system around Home First, but that includes our care sector and the voluntary sector about their role and how they can support people within their communities, either on discharge from hospital. So it's much less a statutory intervention, it's more a voluntary or a community-based intervention that does simple things for you and keeps you feeling safe and well. One of the things after a crisis is that you can feel very insecure. So trying to build up your confidence again is something that's best done by the people around you, either your own family or your community. Next slide, please, John. Just in relation to the care market, so I've reported here before about the grant support that's been given to the care sector over the last year. That's continuing. Government's agreed to continue that until the end of next month, the end of June. We have no indication yet whether that will continue beyond that, but it has made a significant difference. And I've reported before, it's just under £16 million worth of funding over a year. So if you just divide that, we've had a further 3 million plus from government. We'll need to see where we are beyond that. And alongside that, the government also agreed some time ago that they would continue with the provision of free personal protective equipment to the care sector, but also to carers, informal carers, which has been really, really helpful and a very strong coordinated approach. And you'll probably see the planes flying into Bournemouth Airport very regularly. We've continued as a way of a very short briefing, a written briefing that's put together by the Director of Adult Social Services, so for us, Jan, and the Director of Public Health, Sam, that just gives some advice and guidance and a kind of update and a weekly briefing to the care sector. And that just keeps them informed and enables them to talk to their staff about things that are coming as well. And that's information from government or from Public Health England, or what we're gleaning locally around infection rates. A really positive initiative that's happened over the last few months is about the volunteers from BCP staff, but also elected members who've been trained and deployed to support care homes across BCP. And that's been really successful, I understand. And there have been quite a few. I think there are members maybe on this committee that's taken part in that, but certainly the portfolio holder has been part of that volunteer team as well. As Sam touched on in his presentation, there's a really renewed emphasis from the NHS about the uptake of vaccines, and they're asking NHS and local authorities to work together about how we promote that. And that, for me, is how we intervene and support the care sector to make sure that staff and residents take up the vaccine where they're eligible. And then the other side of that is there are, as Sam said, there's a low number of outbreaks currently, and in care homes that's been really kept low in terms of it's been individual incidents where staff or one or two residents have had a positive test, and quite often that's been linked to people who were positive 90 days ago, and in the guidance you don't get tested again once you're positive and for at least 90 days, and people are still coming up with a positive test, and so that's just a sort of the remains of the viral, so the viral load within your body that's just triggering a positive test, but normally the second test of that comes out as a negative. So
is that long COVID? Anything to do with long COVID?
It could be. It's not really determined. Public Health England are trying to understand that better so that we know how to react. What it does mean is that care homes are on high alert just to their staff and residents. And then the national guidance around care home visiting changed on the 17th of May, allowing a great number of people to visit residents, and that's got to be applauded, and it means that family members can be much more connected to their loved ones in care homes, and residents going out into the community on trips or visits, as long as they're supported by someone from the care home. And that's given them some aspects about getting out where they haven't been able to for over a year. I think that's probably the last slide. Chair, thank you.
Thank you, Phil. Councillor Phillips.
Thank you. Most in the room know that I work with the elderly, retirement block. The biggest problem we have is that the GPs do not answer the telephones. We know why. I understand. But where is the port of call for people who, home first, they're at home, the carers come once, twice, 3 times a day, and they're on their own a lot of the time, do the 101, and again, they don't get answered, and it's a very long haul. Where's their port of call? Where are you recommending that they link to with the difficulty with getting hold of GPs? And I've seen that on a daily, monthly basis.
Really, it's difficult. A GP would be a good person to have at the moment, wouldn't it? Our advice would always be to ring 111 in the first instance, and list an emergency, and then ring 999 as you know.
So it would be going back into possibly being taken to the hospital and then sorted out
Not,
again and cycle repeating itself.
Not necessarily, because if 111 felt that you did need a clinical visit, then the out of hours GP may call. It could be the South West Ambulance Trust would do a response to either see and treat, or if they felt on that once they'd arrived that there was a need for an admission to hospital, then they would convey to hospital. But normally we wouldn't be looking to people admitted to hospital unless it was absolutely necessary.
But I do know that even when people are ringing the GPs, sometimes the appointments, because the receptionist is not picking up quite how important it is and how desperate the people are. And it could be the mental issues as well, you know, the mix of everything. It's up to 2 weeks now before they can get appointments. It is very stressful.
Councillor Robson, you have a question?
Yeah, thanks, Chair. Phil, the first Home First programme, does that cross county boundaries? So if somebody from somewhere else had a hospital visit here and then go home outside of Dorset, would that provision still go nationwide?
Yes, it's a national initiative. It's called different things in different places, but discharge to assess will be the more called term for it. We've called it Home First because it is about trying to get people back home wherever possible. So the expectation is if it was outside of our boundaries, so it's certainly across Dorset for Dorset and BCP council area, because we're in the Dorset integrated care system. If it was, say, Hampshire or even beyond, we would certainly support someone to be discharged from hospital and then would look to wherever they're from. If it was we would support them in the short term, and then if necessary, help them to be transported back to their normal place of residence.
Thank you. Anybody else? Phil, could I just ask, there was a consultation a little while ago about care home staff being told they had to, whether they had or not to be vaccinated, whether it was going to be compulsory. Do we have any results from that yet?
We don't. The consultation has ended, I think, and so we're waiting to see how the government reacts to the feedback it's had from many people, including our own. We gave a balanced feedback that included input from elected members, from care sector representatives, voluntary sector, etc.
Okay, so we look forward to that then. Thank you. Anybody else? No? So can we move on to agenda item 10, adult social care, point of first contact service. And can I ask Tim Branson, Head of Access and Carer Services, Adult Social Care, who's on our Teams meeting, to introduce and present this item, please? Thank you, Tim.
Thank you, Chair, and good evening, members and everybody in attendance. Thank you for providing an opportunity for me to come along and update you on the developments to transform our adult social care front door. As you'll know, we did present a paper just over a year ago. I think David presented that, and that was really just explaining how the work that we had done with our partners KPMG to develop a blueprint for a future model of our front door was developed, and how we were planning to take that forward. And so we were, I think, just obviously into that stage then, sort of January, February time of 2020, when we were expecting to be able to start work to progress, the developments of the front door. And clearly, not long after that, we were hit with a pandemic. So clearly, there has been some impact of that, which I have highlighted in the paper to a degree. But just to recap very briefly, the main aims were to harmonise the different legacy service models that we had across Bournemouth, Christchurch and Poole prior to the council forming. We wanted to enhance our response at the first point of contact with more experienced social care practitioners, including occupational therapy support. We were looking to improve our early intervention and preventative responses, leading to a reduced demand for long-term support, and promoting a strengths-based approach which was compatible with our organisational design, and very much was engineered really to sort of support our community resilience. So I've highlighted in the paper some areas where we were obviously able to progress despite the pandemic. The most notable one being the fact that we were able to harmonise our legacy front door models, and they were rebranded to create a single point of contact, which is now called the Adult Social Care Contact Centre. So it really doesn't matter now, irrespective of where any of our residents live within the conurbation, they will have the same response and the same ways of being able to reach us. Secondly, we introduced what we've called a conversation record, and that's recognising the need to move away from an assessment per se to a more meaningful conversation, which starts to draw out the things that matter most to people, listening to their concerns, and then helping us through those conversations to identify the assets, the strengths and the abilities, the resources that people have available to them, and wherever possible, capitalising on that before having to sort of progress and consider more traditional sort of commissioned responses, really. One of the other things that we've been developing is our closer working relationships with voluntary sector colleagues and community and neighbourhood groups. And we've also been working quite closely, particularly through the pandemic, with colleagues in community development. I've highlighted in the paper some of the work that we've done to support the Together We Can initiative, particularly around triaging requests where people were needing access to food support, because that was something that we were quite experienced in doing previously. So we were really able to help our TWC colleagues in that respect. And I guess that is probably one of the few positives that have come out of the pandemic for us is the fact that we've I think built on those relationships, and certainly I think it's fair to say we work a lot closer with colleagues in community development now than we ever have done before. I have highlighted in the paper again the fact that COVID has had a number of impacts, and I've outlined those through paragraphs 10 to 13. So without labouring the point here, I'll allow you to sort of read through that. The emerging outcomes, I think, and that's where we probably are able to kind of give you the most up-to-date information. So whilst we're continuing to develop our performance dashboard, we've captured some emerging outcomes from limited data that we've extracted sort of since January of this year. And that shows that sort of 65% of contacts were resolved without the need for further assessment, and things like safeguarding contacts where we've been able to divert around about 50% of contacts that are coming through without the need to progress through to a full-blown safeguarding response, which clearly has some benefits for the individuals not having to be sort of taken through that process. But obviously that has some cost efficiencies for us as well. And then really moving on, in terms of the next steps, there's still quite a bit that we need to do, and there's some catching up, I guess, because of the impact of COVID last year, which did inject some delays into what we were trying to do. We are about to embark on some further recruitment for some additional outreach officers, which will help with our face-to-face response and capacity to be able to undertake home visits. We know we've got some issues still with the telephony system and the fact that we're now all on Teams telephony, but we do need the integration of some additional software, which is called Anywhere 365, which will help us with sort of real-time data and demand management. There will be things like reviewing our assistive technology offer at the front door, because we know that that's clearly important to be able to get support to people quickly, that will result in their situations improving and therefore not escalating to needing a higher level of support down the line. We're enhancing our occupational therapy and early intervention responses, and that will also link in with the support that we give and the oversight that we give to the outreach officers and that early intervention service that we're developing. We are working with commissioning colleagues to develop My Life, My Care, which is the online platform at the moment that enables members of the public and other professionals to understand what resources are available in the community. But we're wanting to make that more interactive and just upgrade it really so that it becomes more intuitive. We've got opportunities, I think, now to improve our linkage with our carer support centre, Carers Support Centre has recently come under my portfolio as well, so I'm really keen to see how we can improve that connectivity. We will need to do things like agreeing our physical office space and our satellite working, as I said in the paper. Obviously, because of the pandemic, we've had all of our staff scattered and sort of home working, which isn't ideal in terms of promoting that sort of shared learning. I would much prefer it if we could have at least a cohort of staff who from time to time have the opportunity to work in a single base and sort of share learning through experience as they go day to day. And then I guess lastly, we will be looking to work closely with our strategic improvement partners now that they've been appointed to develop our digital offer at the front door as well. So some good progress despite some fairly significant setbacks through pandemics, but clearly a lot of scope to do more. So that's kind of in summary where we've been over the last 12 months or so. But I'm very happy to take questions, Chair, if anybody has any.
Thank you, Tim. Members, anybody got any comments or anything want to ask about the point of first contact service? Councillor Butler.
Ask for the phone number that people can use if they want to access the contact centre.
You can indeed. It's 01202 123 654.
Thank you.
Tim, could I just ask you a question? I like the idea of these community hubs that will be set up. Are we close to setting any up yet? I presume we're going to use some of our own assets like libraries and that, so that nobody's going to be too far away from being able to access this information. I just wondered if you could just give us a few details.
Yes, certainly. The discussions are ongoing at the moment. So obviously, prior to BCP, we had a front door base at the Civic Centre in Poole and a front door base at Care Direct in the Town Hall at Bournemouth. What we recognise, obviously, is that with the likely closure of the Civic Centre in Poole, and recognising the fact that we've got obviously a broad spread now in terms of our geography, that we don't want people necessarily having to travel large distances to either get to, assuming that we're based in the Town Hall, for instance, in the new Civic Centre in Bournemouth. We're still trying to avoid people having to travel as much as possible. So we are exploring how we can use the library hub in Christchurch and similarly the library hub in Poole. So as those two hubs are developing, we're in conversation with colleagues around how we can guarantee that we've got some desk space and the opportunities then to meet people face to face should they need to do that. Although I have to say a lot of what we do tends to be over the telephone rather than face to face in person sort of contact. That's always been the case, really.
Thank you. Good to know that they'll still have access to face-to-face meetings, because even over the telephone, sometimes it's difficult for people, isn't it?
Yeah.
Anybody else got any comments? No? So perhaps we could ask that you bring a progress report to this committee sort of later on, if we put it on our forward plan, sort of, Joe, especially as you said you've got sort of the next steps that you need to sort of go through. It would be good to sort of see how you're doing with those in I'm not sure how many months time. Sort of perhaps we'll discuss that sort of later. Sort of.
I think in the paper, Chair, I suggested that we come back towards the end of the financial year. But,
so about a year from now, then.
Yes, maybe not quite a year, but probably the next sort of 10 months or something like that, I would imagine. But I'll leave that to panel to confirm.
Okay, lovely. Thank you very much, Tim. Thank you.
Thank you.
Moving on, agenda item 11. We've got the Learning Disability Big Plan update. Can I ask Joe O'Connell, Head of Strategic Commissioning of Disabilities, to present this item, and I believe you've also got Mark Harris with you from Dorset CCG. Thank you,
Good
Joe.
evening. Thank you. Good evening, Chair. Yes, I am here, and so's Mark. And actually, we look quite similar. I've just noticed we clearly didn't communicate what we'd be wearing this evening. So apologies if you get us mixed up. But good evening, and thank you. Just to say, it's 12 months since, or just over 12 months since we were here over in the Scrutiny Committee presenting the big plan, and so this was an update report as requested. So just to sort of just over 12 months on, where and really what that sort of progress report really recognises is that this has been a challenging 12 months for people with learning disabilities and their families, and includes some impact of COVID on people with learning disability, but also has had an impact on some of the work we wanted to do as part of the big plan. But so there are some areas within this work plan which you've got before you, which shows you where we have been able to make progress, but also some areas where we just haven't, mainly because most of the staff we've had who would be leading on that work were put into doing other work, specifically on the back of COVID here. There was a couple of areas within the big plan where members asked for us to come back specifically to talk about, and so the report does cover around some of the positive work that has been going on around really trying to promote the uptake of health checks, and a lot of work the CCG has been leading on in trying to really push forward with that in this last 12 months. And also a bit of an update around where we are in terms of our supported employment review and the discussions we've been having with Dorset Healthcare around a review that they're doing around supported employment for people with mental health needs, and with Dorset, and about how we're trying to work moving forward to consider to develop a pathway for supported employment for all of those. I think one of the things we've got to coming forward today is the fact that our big plan was from 2018 to 2021. So theoretically, this should have been the last year of our big plan before we started work on another one. But there is still a number of actions within the big plan that need to progress, and some of those will take a number of years to move forward. Work around how we even continue to move away from our reliance on residential care for people with learning disabilities and develop new supported living opportunities. Also some work we want to do around day opportunities and supported employment as other bits. There's work to do, and at the same time the government have introduced as part of their long-term plan a new roadmap for the next 3 years about what their expectations for learning disability and autism services. So this seems like a really sensible point to think, hang on, how can we combine the work we know we've got to do as part of that NHS roadmap, along with the continued work we want to do part of our big plan, and therefore recommending this proposal that was that rather than stopping the big plan as it is, but and starting over again with a whole new strategy, to extend our current learning disability plan, focusing on the 7 big aims, which don't really change. They're the areas of real importance for people with learning disability, and a request to us to do some work on refreshing our work plan to move forward and aligning it with that roadmap, and taking this and to enable us to continue the work right through till end of March 2024. That would enable us to go into 2023, actually do some much more a full piece of co-production around a new big plan there afterwards, with individuals, and hopefully in a much brighter world where we can get back in the room and engage people fully in that. And at the moment, for the next 2 or 3 years, really just continue a lot of the work which we started in earnest, but has been delayed. That in a nutshell is really what this report is here to do. I'm more probably best thing is really to ask other areas of particular where you'd like to ask any questions.
Members, anybody got any questions? Perhaps I could ask Joe. I see this has always been an ongoing problem where it's sort of finding work or for people with learning disabilities. And I see you've included sort of helping them set up their own businesses. I mean, we have in Bournemouth itself the excellent Crumbs project where they train people in the hospitality trade. So hopefully that they're sort of reopening up again and taking people back in, sort of training them to take up jobs. Well, in that particular case, in the hospitality. Do we know of any other places like that locally?
There of schemes which we've identified as part of our supported employment review, and actually we've been having a lot of conversations with Crumbs just in these last few weeks, because as part of their plans to reopen, and they are changing some of what their offer is, and so we're working with them to understand what that new offer is and making sure that it works well both for the adults that use that service, but also linking with our children's preparation for adulthood team to understand about how that might work with them for young people coming through as part of that pathway and learning skills then to get into real work. And much of our supported employment review is saying what we need to focus on is how do we get people into through that supported employment offer that actually can increase their chances of actual paid work. And some of our services we would describe perhaps as sheltered work opportunities, where people go and get training and then from there might move on to be placed into the world of work. And then there are other services we have, well, we want to develop more, which work on the principle more around supporting individuals to get them actually into the world of work first and train them on the job there. And actually what all the best government and national advice around that says is you stand a far better chance of getting people into the world of work if you can work a model that actually places and trains rather than does the training first and then seeks to place. So we are trying to work a pathway up together that sort of encourages us to work more in that way and looking at how we can do that, but then also recognizing that some of our sheltered work opportunities still do have a place. We have services like Chestnut and Cherry Tree Nurseries, do some really good sheltered work with the people out there. Coast, our service within Tricuro, and also Roots, some of our other services that do offer levels of supported employment, and it's about how we work with them to try and increase the opportunities of getting people into real work.
Thank you. Councillor Butler.
Yeah, I'd just like to add to that, Joe. Some of the shops are very good at employing people with learning disability. The co-op are excellent, and they've got a very good ethos of helping anybody with physical or learning disability. And also, when I worked for Dorset County Council, we used to have a community employment scheme where our work was to find voluntary work or paid work for people with all sorts of disabilities. So there's an awful lot out there that people can do according to what they're interested in. And I think that's probably the key, that a lot of voluntary work can then become paid work because you need the experience to become employed. So it's sort of a two-way process. Also, Upton Country Park has got a scheme, hasn't it, with the tea room where they have people helping there. So,
yeah, that's right.
Yeah, so we're quite lucky in this area.
I think we are, but I think there's always more to do. I think you know, the sort of the measure for this sort of about how we're a judge for this would say that there is further work. That's not just a local issue, it's a national issue, and I think we really want to use this review as an opportunity to build on where we are at the moment and increase those opportunities.
Thank you. Could I also ask about the health checks? I noticed not all of the people managed to get their health checks. Do we sort of, how do we deal with the ones that haven't managed to have their sort of annual health check?
Should I take that one, Joe? So I guess health checks have been a challenge for us over the number of years, really going back. We certainly haven't hit 100% in any time that I've worked in the CCG. But that is a national issue, and I think what we've had is a sort of renewed emphasis and focus because of COVID, and the sort of the health inequality of making sure that we sort of really address that and improve the uptake of health checks. One of the challenges with that, I think, has been around primary care, obviously, and the pressures within primary care and the changes that have happened over the last year or so. We have got a dedicated work stream and focus now on trying to sort of pick up and improve our uptake of health checks, and sort of some of the key actions around that are sort of working with the local People First Forum to sort of co-produce some materials and some toolkits that practices can use, so that when people come through, they're actually getting a good quality health check. That is one of the issues that we're really keen to address as well, is that making sure that when people do get the health check, they have a good quality, high quality health check, because we have had feedback that on occasions that hasn't been the case. I think another aspect that we've been working on is to look at making, we've just developed a sort of a business intelligence dashboard, which now gives us a lot more sort of improved visibility of real-time surveillance and such, or real-time intelligence around what practices have got high levels of uptake, what areas they haven't, which then enable us to sort of go through some targeted work with those particular practices. We've identified champions in each of the primary care networks. Sorry, not each, but we've got up to about 60% of the primary care networks across Dorset that have got identified health check champions, and we have plans to get the remainder of those PCNs, or primary care networks, identified leads within the next couple of weeks. One of the things that we want to do as part of that sort of intelligence picture that we get now is where people haven't come in for a health check in the preceding 12 months, is we're going to engage non-statutory or non-professional, non-sort of qualified staff as such, and use social prescribing and other alternatives like that to really go out and engage with the cohort of people that need to come in and encourage them to come in. Another dedicated area that we'll be working on over the course of the next year is around looking at the sort of cohort of people from age 14 to 25. So again, focusing on young people and thinking about trying how we communicate the benefits of them having a health check as well, because we recognise that that's an area that we need to improve on too. And lastly, I would say is what we have done is developed bite-sized lived experience films. So again, working with our colleagues in the People First forums across BCP and Dorset, we've created some small bite-sized sort of films that can be used with the cohort of people that need those health checks to understand what it's like to go forward, what to expect. We know that there's mixed views about that out there in the community, and part of the challenge is around getting people to want to come for the health check as well. So it is a work in progress, and we are aiming to sort of continually improve that percentage up as high as we can go.
Thank you. Anybody else got any questions? No? Can I ask members to support the proposal to extend the Learning Disability Big Plan until the 31st of March 2024?
Agreed.
Is that everybody? Yeah, agreed. Okay. Thank you very much.
Thank you, everybody.
Right. Thank you.
Thank you.
Moving on to agenda item 12, the portfolio holders update. Is it Councillor Karen Rampton? Are you going first, Karen?
I can do, thank you, Chair. Can I firstly offer my congratulations to yourself and to Councillor Evans on your appointment as Chair and Vice Chair, and look forward to working with you over the next 12 months. Just a couple of things. I'm not going to go on for too long. Just wanted to mention it's Carers Week from the 7th to the 13th of June this year. And the theme this year is making caring visible and valued. So that's something that I'm sure members will want to take note of and engage with in whatever way they can. I think I'm due to do a sort of podcasty thing, and hopefully that's not going out to too wide an audience. And that's been filmed this week. The Adult Social Care Contact Centre, the agenda item, we've got the seminar on the 20th of July, and I wondered if perhaps Joe could send out that date, Chair, with your permission, so it can get into members' diaries, because it's going to be a really, really interesting seminar, and there are some really good case studies which kind of prove the worth of the contact centre. So I think it's 5 o'clock, and I'm sure it's on the 20th of July, if perhaps Joe could check that and then let members know. Thank you. Mentioning about volunteering in care homes, I have been working, well, not working, but I'm going in as a volunteer to a care home in Poole, which has been a really interesting experience. There was quite a lot of training to do, including doffing and donning, which is the way that you put on and take off your PPE equipment safely, and that was quite an experience, doing it all virtually, of course. But I've been going into the care home and really just kind of chatting to people and making cups of tea and coffee and joining in any activities that they've been doing. So it's been a really worthwhile experience. Probably coming towards an end because it's pretty well staffed, and because there are so few cases of COVID now, there's probably less need to go in. But I would absolutely recommend anybody, if they get the opportunity, to do some training and to help out. It's really rewarding. I suppose the other thing I wanted to mention was the strategies which are coming forward over the next few months. We've got technology-enabled care, and we're going to be starting an options appraisal for that very soon, and that's going to be something that I'm sure members will be really interested in. We're going to have a market position statement. It's going to be completed by the end of May, and that will inform the strategies which I think are already on your forward plan, the care home strategy and the extra care housing strategies. And they're due to come to Cabinet probably sometime over the summer, but of course to this committee first. I think they're on your forward plan as TBC at the moment. And there is going to be a day opportunities review, which will be a co-produced strategy, and there's going to be lots and lots of engagement, obviously as COVID aware as possible, but a lot of engagement on that one. Really important piece of work. So there's much going on in this area, and I'm happy to take any questions, Chair, that members might have. Thank you.
Thank you, Karen. Anybody got any questions for Karen? Thank you, Councillor Robson.
Yeah, thanks. Yeah, I was just wondering, there seemed to be, just going back to the Home First point again, that there seemed to be an issue with perhaps people dialing 111 or 999 and not getting through to who they need to do quick enough. Is there any plans or any work being done on how we might improve that service so that once the carer has left the Home First service, that the person left behind has got another number or another sort of stream that they can get hold of somebody a little bit quicker than holding on the line on 111?
Chair, I think that's probably an operational question that that one of the officers could answer. Thank you.
Thank you. David, yes.
Thank you, Chair. I'm probably less able to answer questions about 111 and 999, which are provided by the NHS. But what I would say is that for people who are part of the Home First programme, they'll be supported at home by social workers, occupational therapists, reablement teams, intermediate care teams, and that will include community nurses, primary care networks, so physiotherapists as well, and so those people will be surrounded by a network of care, and they'll have contact numbers so they can call their regular nurses or social workers or occupational therapists. So although that's not an emergency response, there is a full response around that individual, and certainly for social care there's an out-of-hours service as well. So the Home First service is absolutely not leaving people adrift once they come out of hospital. They are surrounded by a very comprehensive package, and that's something, as Phil mentioned, that we'll be looking to develop as a much more regularised service for the future.
Thank you, David. I believe Jan wants to come in on this as well.
Thank you, Chair. I just wanted to highlight that if you looked at your forward plan at the items that have been for a while under a possible joint scrutiny area, there was actually an idea that you might maybe together with Dorset Council, want to look at both ambulance response times and 111 service, which is, you know, there have been relatively recent, pre-COVID, but relatively recent developments in those services. So I just wanted to highlight that, given the interest tonight in those areas.
Thank you, Jan. Yeah. Okay. Anybody else got a question for Karen? No? Sorry, Karen, no more questions. So can we move on to Councillor Nicola Green, please? Thank you.
Thank you, Chair. Thank you, Chair, and good evening, panel members. Councillor Edward, Councillor Evans, congratulations on your election tonight, and like Councillor Rampton, I look forward very much to working with you. I was going to start by congratulating the panel for being so very efficient and combining items 9 and 12 on your agenda in terms of the COVID update and how that relates to that part of my portfolio. Clearly, I'd been very happy to take questions at that time and can do so now if you'd like to revert to that. But one thing I would like to mention in addition to that, if I may, and following on from the previous agenda item that you had, is again another strategy which is coming through, which, while rooted in children's services and the education part of my portfolio, is also linked very much to the preparation for adulthood aspect of the special educational needs and disability improvement work that's going on. You may have seen on your cabinet papers for this Wednesday that the SEND strategy is coming through. And just to give you, those of you who've not got it in front of you, it's really centred around the vision that all children and young people who of course then go on to be adults, it's about making sure that they've got brighter futures. And the 3 areas where we focus are experiencing inclusion in every aspect of their lives, achieving their full potential, and being partners in developing provision and services. And it's particularly in respect of those last 2 items that I think your panel may have a particular interest. And there are 5 priorities to the strategy, and the 3rd of those is that young people are prepared for adulthood and to achieve their full potential. So it's, you know, we don't just have that cut-off between children's services and adult services, but for some of our more vulnerable residents, they move we would hope, in a rather seamless way from the children's area and the children's scrutiny into adult services and into the remit of your panel. And we know, actually, from listening to them, that for many of them, the actual move isn't that smooth as it can be made to sound. So I don't know, Chairman, if you'd like to keep, or members, if you'd like to keep this under review in your panel. I'm very happy to come back to you and speak as we move forward in implementing the strategies which go alongside that strategy, assuming it's adopted by Cabinet and then onwards to council, but it is an area which really straddles for those members of our community, both children's services and adult services.
Thank you, Nicola. Yes, I think we'll bear that in mind, for a future meeting, a progress report on that. Thank you. Anybody got any questions for Councillor Green? No? No. Thank you, Nicola. Short and sweet.
I've been called worse. Thank you, members. Thank you, Chairman.
If we move on to agenda item 13, the Joint Health Scrutiny Protocol, which is not a simple document, but Jan and Karen Tompkins will give us an introduction and explain the draft version of this Joint Health Scrutiny Protocol between Bournemouth, Christchurch and Poole Council and Dorset Council. Thank you. Jan, are you going first? Thank you.
Thank you very much, Chair. So, as members will be aware, there is a provision in statute that enables health scrutiny committees to operate over a larger geography than just one council area. And this protocol is a protocol between BCP Council and Dorset Council about how that joint scrutiny function would be administered. I just wanted to draw attention that members will have received an email with an updated version of agenda item 13 on Friday, the 21st of May. And the changes all relate, and I will talk to them about them, to the issues in item 10. So in terms of why a committee might do joint scrutiny, there could be two areas. The committee themselves could say, this is an issue that affects all our residents. We wish to do this together. It will be a more efficient way to do it, and we won't be requiring the NHS particularly to come and talk about it twice. And we've just talked about, for instance, on your programme, there has been a long-standing issue about whether you wanted to revisit some issues that had come up in previous years, particularly about ambulance response times and the ambulance service, but also some of the responses to the public who don't have a 999 call but actually want attention in a urgent situation or a urgent situation rather than the emergency situation. The second reason why there may be a joint committee is that the NHS may be proposing a significant variation in local health services. And in a situation where they're proposing a significant variation in health services, which covers more than one council area, there is really an encouragement for the NHS to present that to the right geographical area. Now, we have a protocol here that says normally that right geographical area would be the BCP and Dorset Council areas, given that we have both a clinical commissioning group, but also a number of providers, our hospital trust, but also our Dorset Healthcare Community Trust, which actually serve the residents of both council areas. But the protocol does acknowledge that you could have an issue that actually touched on further boundaries. So, for instance, Hampshire residents do use our local hospitals. So it makes provision that by agreement with the chair, that could also happen. So the basic, we've tried to make this as straightforward as possible. So in terms of administering a committee, the council, there would be an agreement about which council was going to lead on that specific item. It could be either, and once you've agreed in terms of which council will lead, that council administers the process, and the chair of the committee comes from that council for that particular sequence of scrutiny. We've also looked at the number of members and said that actually that could vary depending on the issue. So it could be anywhere between 3 members from each council or 5 members from each council would participate. That would include the chair and the vice chair of the committee. And that's an acknowledgement that over the years we've had different orders and magnitudes of issues which have attracted different levels of interest. So that would be for really related to the particular issue that would be under consideration. And we've also agreed that the chairs of the committee would agree which items should come forward, obviously in consultation with officers, but also no doubt in consultation with committee members. So would have an agreement about that an item should be brought to a joint committee, and that joint committee would receive a scope of that scrutiny at its first meeting. This is all simplified from our former 3-way process, which meant it was a very lengthy process to get a joint scrutiny up and running. So this is designed to be a way in which joint scrutiny can happen in a more simple and quicker way. As members will also be aware, and this is where we come to item 10, This committee, and indeed Dorset committee, and any health scrutiny function, would have the ability to refer to the Secretary of State a significant variation in local health services where there were valid reasons that a council committee was saying, we do not believe that this is in the best interests of our residents. Now, that is a very specific power which is exercised by this committee. When a joint committee is held, that joint committee can be delegated that power. So the joint committee could be delegated by both councils that power. When it has been delegated that power and it makes a decision, what this protocol is saying is that it would be an absolute exception for that decision to be overturned or withdrawn by either council. And that process, if it was withdrawn, would not be down to this committee. It actually would be the full council procedure, which is the procedure for withdrawing any delegation to anything across the council. So what we have discussed with NHS colleagues is clearly if a joint scrutiny is held, from their perspective, it is important that the outcome of that joint scrutiny committee is valid, and it's only in exceptional cases that it could possibly be withdrawn. So that captures the process that we're talking about, and it's really trying to make clear that there would be, once a decision is delegated to health scrutiny, then it would be that the health scrutiny committee does have the power to decide on that item, including referral to the Secretary of State. When joint scrutiny happens, as indeed individual scrutiny happens, NHS organisations presenting to that joint committee would be written to with the outcome, and if there are requests for action, timeframes would be given to those actions. And also that I know that we have Louise Bake with us from Health Watch. We thought it was important that the role of Health Watch on the joint scrutiny panel was also acknowledged, and that there was consideration given to the role of Health Watch in joint scrutiny work. And finally, the protocol would suggest that each council's committee receives a report on the outcome of a joint scrutiny piece of work.
Thank you, Jan. Anybody got questions? Councillor Wilson.
Cheers, thank you. Just a couple of things. I just want to understand how a power would get delegated in the first place. Would that be through the leadership or the chief executive, or how would that work? And just a technical one on the numbers, because at point 3 it says about each joint health group committee will comprise of between 3 and 5 members. However, the next point down says the quorum for each meeting will be 2 from each council. So would that mean that a meeting comprising of 3 members would not be quorate?
Would you like Karen Tompkins to answer these questions, Jan? Or
no, I'm happy to.
Okay
I'll start with the second one, and then we'll bring Karen in as well around the delegation. So if I start with the second one, and then Karen can approach the delegation. So in terms of the quorum, what we are saying is that at minimum a joint committee would be 3 members from both councils, so it would be 6. So would the minimum committee size would be 6, so it would be 3 from each council. What we're acknowledging, so that would be the appointed numbers. What we're acknowledging is that there are occasions with the best will where a councillor can't get to a meeting. So for a meeting to be quorate, it would need at least 2 councillors from each council to be present.
Okay.
Does that make sense?
Okay. So then should it probably change in the wording on point 3? Have I got it wrong? Just that it will comprise between. Okay.
Yeah,
I think I've read it
Yeah,
wrong.
yeah,
Okay,
it does say
fine.
2 from each
Yeah,
council.
Okay, cheers.
So I'm going to just let Karen talk first about delegation in this context.
Thank you, Jan, and thank you, Chairman. In relation to the delegation, I would suggest that that's a consideration in context of identifying the nature of the scrutiny at that particular point. And clearly, I think it needs to be identified as to if that delegation and that ability to refer to the Secretary of State, if that's a significant variation, is applied in those circumstances. So I think it may well be that it's on a case-by-case basis, but I mean, we can go away at this particular point and check those issues out. Obviously, just to emphasise, this is the joint protocol, so colleagues over at Dorset Council will be going through a similar process in taking this protocol through their respective overview and scrutiny committee. So hopefully that helps in responding to Councillor Wilson's question, but happy to come back.
I think I understand that. So, yeah. Cheers.
Thank you, Karen. Councillor Butler, you have a question?
Yeah, I'm just a bit worried about the few numbers of the joint committee and who has the final say, comparing what we have now with the 2 committees, which have quite a few of us in each area of Dorset, and then going down to just a few people who you know, agendas could crop up if there's just a few people who make the decisions. So that's just a worry, really, of who has the final say and who has the most power, really. You know, is it seen that it's just going to be taken on occasion for the occasional thing to discuss, and that we discuss all the other things? Or would the joint committee always have items to sort out together?
Are you happy to take that?
Yes, over time, the joint committee has been used in relatively limited circumstances, and the protocol would say it is the chairs of both committees who will look at the forward plan and say are there issues here which particularly are relevant for joint scrutiny. So over time, the committees themselves have chosen in relatively few circumstances to do joint scrutiny. For instance, there was a joint scrutiny previously around, as I said, around the ambulance service and response times. And I think probably the people involved in that felt that worked well. As we've got here is what's really important is that's very transparently reported back to both committees. In relation to significant changes or variations in health services, the NHS has, in more recent times, actually itself decided to say to committees, would you like to hear this separately, or would you like to hear it together? So at your last committee, you had a report on what is a very large estate development programme across BCP council area and Dorset area for hospitals, and actually the NHS itself said, can we come and talk to the committee separately, because we think that's probably better because some of the issues are different in geographical areas. So over time this hasn't been used very much. We do have to emphasise though that there is an encouragement in the guidance and legislation to use joint scrutiny when there are significant variations which cut across council areas. But we've had a conversation with the NHS that where they have said they would rather have the conversation with the chairs first about would you rather do this together or separately, so that actually they engage with councillors in the way that feels most relevant to yourselves.
You okay, Diana? Councillor Robson.
Yeah, I think mine's a bit of a follow-up to that in a way, is ballpark figures sort of thing. How many times would you see that joint committee sitting, and how many issues would join up across both councils as opposed to sort of individual council business?
Jan?
Well, I think I can probably only call on history rather than saying, so in terms of what's happened in the last 2 years, we had the committees have had one joint scrutiny committee, which was last June, July, which was to look at the NHS response to COVID, and was very much around the context of just the very high demand on the NHS and the absolute need to minimise at that point the demands on key individuals in the NHS, and that was done jointly. So in the last 2 years, we've had, I think, and Karen or Joe would correct me, but I think we've just had one. Previously, there were items where it worked very successfully. So I suppose this is about, and there were items which were taken to a joint committee, which I think we've all reflected on in this joint protocol. And they were particularly about the clinical services review, which was taken to a joint committee and then was separately, subsequently, when delegation was removed, taken both to Dorset Council and then to Poole Council. So I think that history has made us think very carefully around this protocol, because I think probably people feel a process, and it was commented on by the individual review panel, which looked at the referrals by the Secretary of State by both Dorset Council and the Borough of County Council and the Borough of Poole, and commented on the process, which from their perspective they said was not a good process in terms of getting to referral to the Secretary of State. So this protocol makes a clearer that issue around probably think very carefully across the two councils and the NHS around a significant variation, and think very carefully about if you're creating a joint scrutiny committee to look at a significant variation, you need to bear in mind that that will have delegation, and its decision shouldn't be withdrawn unless there were absolute exceptional circumstances. So we're learning from that process. I just would want to emphasise that there have been issues which were very successfully, and I think councillors involved in those processes felt were very appropriately looked at. And it does, if you have a particular issue you want to consider, it does mean that NHS colleagues do not have to duplicate what might be the same activity. But it hasn't been that frequently used.
So with the deciding factor, if there's 4 people, oh, I'm so sorry. Yes, if there are 4 people on the committee, who takes the final decision within that discussion?
Well, Karen might also want to come in on this, but I suppose what I wanted to highlight is probably the majority of the joint scrutiny work has been where members have wanted to look at an issue in depth, and that's been a good way to look at an issue in depth. So it hasn't been one where there's necessarily going to be a vote or a decision. There's probably going to be recommendations that people might all agree on. In a situation, I think where it was, and I am going to look to Karen to come in, because it on the, if you've got an even number of members, where the casting vote is, Karen.
Just in relation to, before I get to that one, I agree with you, Jan. I think it's emphasising that there's been that consensus of opinion previously with regards to joint scrutiny work on those issues that are the subject of discussion through that process. But if you look at the protocol, obviously it would identify which council is going to take the lead on a particular issue, and therefore identify that the member of that lead council would potentially be in the chair. So there would be a casting vote of that chairman. So if that helps, that clarifies the position.
Does that help? Councillor Hobson asked. Yeah.
Sorry, yes, it does. Yeah, thank you.
Anybody else got any questions about it? Councillor Butler.
Sorry, just to come back. Surely we like to work with Dorset Council anyway on different things. You know, things like the Heathland and things like that we share. But could we do this in a less legalised way, that we could just talk to each other and share things to be put forward, or does this really have to go through the legal process?
I would say some of how this is developed is meant that once you're in a scrutiny, you're in a formal process, so it needs a protocol. Part of how this has been designed is that the chairs on behalf of the committee can have that conversation about, is this something we wish to do jointly, and then this sets out the manner in which that would be done. What we do have to be aware of is that in terms of significant variations, there is an encouragement to undertake them on the geography for which they are impacting. Now that's an encouragement. What our NHS colleagues have said to us in the course of developing this protocol is that actually if both councils committees were saying this is an issue which we ourselves feel is so fundamentally important and may also have different consequences for our residents from a neighbouring council's residents, then actually we would rather have the discussion early around should this be a joint scrutiny enterprise, or should it be a separate scrutiny in each council area. So they are saying, I think very similar to yourself, Councillor, that they would really wish to have that discussion before any decision is taken around is joint scrutiny the right way forward or not. Once it's agreed that it is for any matter, we need a protocol setting out how it would be conducted, because it is a formal committee like any other committee of the council.
Councillor Evans.
Thank you. I realise it's very difficult for you to see me. Just going back to the point about the casting vote, does that need to be specified within the protocol, because it's not actually in there?
I suppose I'm just looking to Karen. I suppose my answer might be, if we're using we'll be using the
Wait, do you want me to? I think
the governing rules for whichever council is running it, won't we, Karen?
Absolutely. Just for clarification, if we as BCP Council were taking the lead role, then obviously we would be using our constitution and our processes in the context of meeting and how we operate our meetings currently. And equally, if Dorset were taking the lead, they would. We can certainly sort of clarify that position from that perspective. But I mean, if you were sat in committee now and you had an equality of votes, then obviously the chairman would be taking the casting vote.
Okay. I mean, if we look to our forward plan, numbers 28 and 29, we do have there where it says possible joint scrutiny with Dorset Council, and one is on the South West Ambulance Service Trust Improvement and Financial Investment Plan, and the other is on the implementation and performance of NHS Dorset Urgent Integrated Care Service. But it only says possible. We may decide that we don't want to do it with Dorset Council, that you know, we've got enough in our own area that we don't have the same things in common with Dorset on that. So we may say, well, we'll just scrutinise it just through this panel itself, or we may say it crosses over into Dorset and therefore we need to do it as a joint scrutiny with them, so that we don't double the work up for them. That's all. So, Councillor Robson.
Yeah, that was what I was thinking there. Surely would be these important issues we'll be talking about independently anyway, so that when we go to joint committee, the BCP point of view on this issue is A, Dorset point of view is possibly A, you know, B gusting A, but we'll come to some sort of conclusion at the joint committee. Is that, Jan, how you see that working? Or?
I suppose I want to say two things. This is a permissive document, so it enables you to, it gives you a mechanism to do it jointly. It gives the NHS a mechanism to say we have a significant variation, and actually the guidance would say if it affects a larger area, you should do it jointly. But as I've said, they would want to work that through with the councils. So it's, and I suppose what I would be saying is that it might, you could see there would be a significant variation. You might well have a discussion. I suppose what I would be saying, I don't think what you would want to do is have a scrutiny session and invite NHS colleagues to present it in one council area and then go into a joint health scrutiny committee, because that wouldn't be good use of our NHS colleagues' time. What this is saying is the chair on your behalf would talk to the chair of Dorset, and where there was an item that you felt would be well suited to joint scrutiny, you'd progress it in that way. And no doubt, as you say, members representing this committee would no doubt go taking soundings and views from colleague committee members in an informal way.
Thank you. And any more questions on this item? No? Okay. If we move on to our forward plan then, please. Oh. Okay. Okay, sorry, before we move on to our forward plan, so do members agree to the joint health scrutiny protocol between Bournemouth, Christchurch and Poole Council and Dorset Council?
Can I ask if there's a trial period? Have you set sort of any time scale to it? Is it a what, maybe?
It is. It's updated because the previous the protocol for the previous councils was different, and we have actually tried to make this more of a dialogue initially, to and one that would mean that health scrutiny could be stood up more quickly and easily if that was if the chairs and committee members were reminded to have that. There is no reason. And I'm looking to Karen here, why there couldn't be a recommendation that, you know, the protocol is reviewed in after a certain period of time, Karen?
I think that's entirely acceptable if the committee wish to indicate a review period. And indeed, as I said earlier, the equivalent of this committee over at Dorset Council will consider the protocol. I think it's in early June, so they will have the same document. They may have the same view, but we can keep it under regular review. I think the importance, as Jan has said, is this is a simpler process and does give that flexibility and that initial opportunity in the context of having those discussions to identify those areas of joint scrutiny that both committees want to take forward.
Thank you, Karen. Would we therefore want to wait to see what Dorset say about this protocol, to see if they make a recommendation?
I don't know whether Jan's got any comments on that. The only issue is that if we do have any topics that are on the horizon, you've just referred to 2 possible topics within your forward plan. If we could get maybe agreement to the document as drafted, subject to feedback from Dorset, it does then give us an opportunity to use it going forward fairly quickly.
Jan?
I was just going to say the same. I think it is important that we have a protocol because it is a provision that exists. So we do need to have a protocol governing this. But I was going to suggest that you might want to, if you were minded to approve it on behalf of BCP Council, subject to Dorset's decision on the 8th of June, that you might want to say that you would like a review of the process in no less than 2 years' time, to see how it's working.
How do members feel about that? Good compromise, yeah? No? Okay. So, yeah, okay, thank you, yeah. So, yes, the forward plan. So we have moved one of our meetings to the 28th of June. So we've got several items on there. Social care developing market statement, which Phil will be presenting. Yeah. And I think we've got the older people's care home strategy and the extra care housing strategy. That's to be on the June meeting as well, is it, Phil? Yeah.
Yes, Chair, that's correct. We just need to fill in the boxes. Joe and I will work on that and make sure they're populated. But the market position statement and the 2 strategies will come onto the same committee.
Thank you. And our usual COVID update and portfolio holders update. And then we've got our 27th of September meeting where we have a Safeguarding Adults Board annual report. The adult social care charging strategy update. And we will have an update from Louise Bate from Health Watch. And then moving on to 29th of November, we've got the Dementia Services Review. And we've got Home First Implementation Review. BCP Carers Strategy. And then we move a bit more forward onto that for other subjects that have to be put into date. Has anybody got any other items that they would like to see put on the forward plan that isn't already there? Councillor Wilson.
Yeah, it's not an item that is on the forward plan currently, but it's just around dentistry provision. I was just wondering if we had any idea when that's going to come to the board, because obviously it's to be confirmed, but I do think that is like a really important piece of work that would be good to look at sooner rather than later.
Funny you should mention that, because we did have a letter that came from NHS dentistry, and we were just deciding that Councillor Evans and myself, and because Councillor Jones had brought it up, we would have a briefing on this as to how we would progress this. But I'm happy if Karen's happy, because she sent it to me originally. That the letter that came from that, if you'd like to have a look at that. So certainly to have some input on that, and we'll see how we're going to go forward with this.
Yeah,
okay.
I would be grateful for that. Thank you.
Okay. Anybody else? Councillor Evans.
I think at some point we ought to look at the Dorset integrated care system as a whole, possibly as a joint scrutiny item as well. So there's going to be quite a lot of changes going forwards, but obviously it's a bit soon at the moment, so maybe for the future plan.
Anybody else? Councillor Robson.
Yeah, it's just a quick one sort of on those both points really. I think trying to be optimistic about COVID moving forward to sort of November, September, maybe that can be quite a reduced item now, and some of these other items we can get up into the main committee rather than leave them sitting in the to-do pile.
Hopefully, yes. It'd be a word of the past. No. So, just before, Councillor Butler?
Sorry, can I just check if we were meant to vote on the Agenda 10 item, which was a recommendation on there? About the point of first contact service, it says it is recommended that.
I think we agreed that to bring the progress report to this committee,
right,
sort of in about 10 months' time, I think was what was said. Yeah. Yeah.
Okay.
Yeah. No objections to that. No.
No.
Okay. So is that everything for everybody? So just before 8 o'clock, I'd like to declare the meeting closed.